Assalamualaikum warahmatullahi wabarakatuh. Perkenalkan, saya Listiana Rahman dengan NIM 170101132 dari kelas Sarjana Farmasi kelas C. Di sini saya akan menyampaikan materi perkuliahan tentang farmakologi 3, yaitu analgetika, anti Parkinson, dan hipnotik-sedatif. Dan mari kita mulai pembahasannya. Kita mulai dari analgetika. Pengertian analgetika. Analgetika yaitu senyawa yang mampu meringankan dan menekan rasa nyeri melalui penghambatan respon terhadap stimulus nyeri pada reseptor opioid. Juga reseptor lain yang terlibat dalam proses nyeri dan melalui penghambatan pembentukan prostaglandin. Sedangkan apa itu nyeri? Nyeri yaitu perasaan yang tidak menyenangkan yang diakibatkan karena kerusakan suatu jaringan, baik di dalam tubuh maupun di luar tubuh. Analgetika digolongkan menjadi dua jenis obat, yaitu analgetika opiat dan analgetika non-opiat. Analgetika opiat sebagai analgetik narkotika atau senyawa obat mirip morfin, seperti contohnya senyawa oksikodon, morfin, nalbupin, meperidin, fentanil, metadon, tramadol, dan masih ada lagi. Sedangkan analgetika non-opiat yaitu seperti golongan AINS, yaitu aspirin, paracetamol, ketorolac, natrium diklofenak, piroxicam, asam mefenamat, dan masih ada lagi. Analgesik tipe antikonvulsan juga termasuk dari analgetika non-opiat, seperti gabapentin, pregabalin, carbamazepin, lamivudine. Dan ada lagi NMDA antagonis seperti ketamin, memantin, dextromethorphan. Juga analgesik tipe antidepresan, yaitu amitriptilin, trazon, duloxetin, dan terakhir relaksan otot seperti siklobenzapin dan baclofen. Di sini ada mekanisme kerja obat analgetika. Mari pelajari video dari channel Speech Pharmacology berikut ini.
In this lecture, we are going to cover pharmacology of non-steroidal anti-inflammatory drugs, known as NSAIDs, as well as pharmacology of prostaglandin analogs. But before we do that, let's first discuss what happens during inflammatory response. So, following tissue injury or irritation, enzyme called phospholipase A2 is released, which converts phospholipids in the cell membrane into arachidonic acid. Now, arachidonic acid is the substrate for two major enzymes, the cyclooxygenase, abbreviated as COX, and 5-lipoxygenase, abbreviated as 5-LOX. In this lecture, we're going to focus just on the cyclooxygenase pathway. Now, the COX enzyme exists in different forms, two of which are COX-1 and COX-2. The first one, COX-1 isoform, is expressed constantly throughout the body, and is primarily responsible for production of thromboxane and prostaglandins, which stimulate normal body functions, such as secretion of protective gastric mucus, regulation of gastric acid, promotion of platelet aggregation, and maintenance of renal blood flow. Now, on the other hand, COX-2 isoform is not expressed constantly in most tissues, but instead it is induced at sites of inflammation. So unlike COX-1, COX-2-derived prostaglandins mediate mainly inflammation, pain, and fever. Now that we discussed the role of COX enzymes in the inflammatory response, let's talk about mechanism of action of NSAIDs. So NSAIDs act primarily by inhibiting COX enzymes, which simply leads to decreased production of prostaglandins. As a result, NSAIDs produce anti-inflammatory, antipyretic, and analgesic effects. Now, based on their selectivity for COX enzymes, NSAIDs can be divided into three broad categories. First, selective COX-1 inhibitors, which include ketorolac, flurbiprofen, ketoprofen, indomethacin, and low-dose aspirin. In the second category, we have relatively non-selective COX inhibitors, which include naproxen, ibuprofen, piroxicam, and diflunisal. And finally, in the third category, we have selective COX-2 inhibitors, which include meloxicam, diclofenac, celecoxib, and etodolac. Now, this relative selectivity for the COX enzymes explains some of the differences in efficacy and safety of these NSAIDs. So the most common adverse effects of NSAIDs occur in the gastrointestinal tract. This is where COX-1-mediated production of prostaglandin E2, PGE2 for short, and prostacyclin, PGI2 for short, plays an important role in the synthesis of protective mucus as well as regulating normal gastric blood flow. This is why inhibition of COX-1 increases risk for GI bleeding and peptic ulcers. Agents that are more selective for COX-1 are associated with the highest risk. Now, the second major side effect of NSAIDs results from inhibition of COX-1-mediated production of thromboxane A2, TXA2 for short. As you may remember, thromboxane A2 promotes platelet aggregation, so decrease in its formation results in antiplatelet effect and thus increased risk of bleeding. This effect is particularly evident with the use of aspirin, which unlike the rest of the NSAIDs, irreversibly inhibits COX-1 enzyme in platelets. Moreover, because platelets don't have nucleus, they can't make new enzyme, so aspirin-induced antiplatelet effect persists even after aspirin therapy is stopped, as it takes several days for the new platelets to replace the old ones. So again, agents with higher selectivity for COX-1 enzyme are also associated with prolonged bleeding time. Now let's discuss the third major adverse effect of NSAIDs, which results from their actions on the kidney. So renal prostaglandins, specifically E2 and I2 types, cause dilation of the renal efferent arteriole, which is important for maintaining glomerular filtration rate. That being said, under normal conditions, these prostaglandins have only minimal effect on renal perfusion. However, when kidney function becomes compromised, for example due to heart failure or old age, the production of prostaglandins becomes a significant factor in preservation of the renal blood flow. So, because NSAIDs decrease production of renal prostaglandins, they also may increase the risk of kidney injury in susceptible patients. Now, the last major adverse effect of NSAIDs that I wanted to discuss results from their actions on cardiovascular system. So while agents such as aspirin with high COX-1 selectivity can have protective cardiovascular effect due to the antiplatelet properties, agents with high COX-2 selectivity can have the opposite effect. In order to understand where this adverse effect comes from, let's take a look at the blood vessels supplying blood to the heart. So under normal conditions, we have a balanced effect between prostacyclin and thromboxane A2. Now, prostacyclin is produced mainly by COX-2 in the endothelium and it's responsible for vasodilation and inhibition of platelet activation. On the other hand, thromboxane A2 is produced mainly by COX-1 in platelets and is responsible for vasoconstriction and promotion of platelet aggregation. So now, the problem arises when selective inhibition of COX-2 tips the balance in favor of thromboxane A2 formation. This makes vasoconstriction and platelet aggregation more likely to occur. This in turn leads to increased risk of cardiovascular events, including myocardial infarction and stroke. Now that we discussed NSAIDs, let's talk a little bit more about prostaglandins. So even though prostaglandins can produce many unwanted effects such as inflammation, they are also responsible for many beneficial effects. In order to harness those beneficial effects, scientists develop prostaglandin analogs, which simply mimic our endogenous prostaglandins. Now, prostaglandins exert their effects by interacting with specific G-protein coupled prostaglandin receptor, of which there are at least 9 known subtypes. The effects of particular prostaglandin may vary widely depending on the tissue and expressed receptors. So now let's discuss some of the commonly used prostaglandin analogs, starting with analogs of prostaglandin E1. Examples of agents that belong to this group are alprostadil, lubiprostone, and misoprostol. Although all these agents are derived from prostaglandin E1, they were designed for different therapeutic purposes. So alprostadil has 2 main therapeutic uses. First is erectile dysfunction. When alprostadil is applied into the urethra, it acts via direct stimulation of CAMP pathway to decrease intracellular calcium levels, allowing for relaxation of trabecular smooth muscle and dilation of cavernosal arteries. This ultimately leads to improved erectile function. Secondly, alprostadil is used in neonates with congenital heart defects to temporarily maintain the patency of ductus arteriosus. So for those of you who need a refresher, ductus arteriosus is a blood vessel found in babies before birth that allows blood to bypass the pathway to the lungs. Although this blood vessel typically closes shortly after birth, keeping it open in certain babies with heart defects may improve blood flow and oxygenation. So infusion of alprostadil relaxes the ductus arteriosus and supports its patency until surgery can be performed. Now let's move on to the next prostaglandin E1 analog, that is lubiprostone. So lubiprostone is used in the treatment of chronic constipation. It works by activating type 2 chloride channels in epithelial cells lining the intestine. By stimulating these channels, lubiprostone promotes secretion of chloride, followed by passive secretion of sodium and water, which increase the liquidity of the intestinal contents. This secretion also stimulates intestinal smooth muscle contractions, which facilitate the passage of stool. Now let's move on to the next prostaglandin E1 analog, that is misoprostol. So misoprostol is another prostaglandin E1 analog, and it is used to treat and prevent stomach ulcers, particularly in patients taking NSAIDs. It can also be used to induce labor. Misoprostol works by binding to the prostaglandin receptor on the gastric parietal cell and causing decrease in intracellular CAMP, leading to decreased activity of proton pump and thus modest inhibition of acid secretion. Furthermore, misoprostol protects the stomach lining by increasing bicarbonate and mucus production. Lastly, by interacting with prostaglandin receptors in the uterus, misoprostol causes softening of cervix and uterine contractions, leading to the expulsion of the uterine contents. Now let's move on to prostaglandin F2 alpha analogs. Examples of agents that belong to this group are bimatoprost, latanoprost, and travoprost. These agents are used ophthalmically for treatment of open-angle glaucoma. They work by increasing the outflow of aqueous fluid from the eye and thus lowering intraocular pressure. Although latanoprost and travoprost accomplish that by interacting with prostaglandin F receptors located throughout the eye, bimatoprost is thought to have a different mechanism of action, which is currently unknown. Furthermore, among the unique side effects of bimatoprost is elongation and darkening of the eyelashes, which makes bimatoprost useful in treatment of eyelash hypotrichosis. Now let's move on to the last group of analogs, that is prostacyclin analogs. Examples of agents that belong to this group are iloprost and treprostinil. These agents are used to treat pulmonary arterial hypertension. They work by increasing production of CAMP, which leads to decreased levels of intracellular calcium in pulmonary vascular smooth muscle cells, ultimately causing vasodilation. This results in significant reduction in pulmonary vascular resistance and enhanced cardiac index. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
Mekanisme analgetika, yaitu menghambat sintase prostaglandins di tempat yang sakit atau trauma jaringan. Contoh obat golongan opiat, yaitu kita ambil contohnya morfin. Mekanisme kerja morfin umumnya dapat diabsorpsi dengan baik melalui saluran cerna. Distribusi, kadar morfin yang terikat dengan protein plasma sekitar 1/3 atau 33% kadarnya di jaringan jantung rendah setelah 24 jam diberikan. Metabolisme, secara umum di metabolisme di hati, morfin mengalami konjugasi dengan asam glukuronida menjadi morfin 6-glukuronida dan morfin 3-glukuronida. Morfin 6-glukuronida 2 kali lebih poten dibanding morfin. Pada pasien dengan gangguan ginjal, efek morfin berlangsung lebih lama, disebabkan karena terakumulasi morfin 6-glukuronida dalam darah. Ekskresi, morfin 3-glukuronida dan morfin 6-glukuronida diekskresi melalui ginjal. Efek samping morfin, efek samping seperti konstipasi, ketidakseimbangan hormon, juga depresan sistem saraf pusat. Dan interaksi obat morfin, contohnya seperti obat pereda nyeri, opiat seperti kodein. Juga obat tidur atau gangguan kecemasan seperti lorazepam, alprazolam, dan juga sulpidem. Terakhir, obat antihistamin seperti cetirizin dan diphenhidramin. Contoh obat golongan non-opiat. Kita ambil golongan AINS, yaitu paracetamol. Mekanisme kerja AINS menurunkan aktivitas enzim siklooksigenase, menurunkan sintesa prostaglandin di jaringan perifer dan sistem saraf pusat, menurunkan sensitivitas ujung saraf dan transmisi non-siseptik pada sistem saraf pusat. Mekanisme kerja paracetamol, yaitu menghambat biosintesa prostaglandin melalui inhibisi COX di sistem saraf pusat, bukan di perifer, serta penghambat proses regulasi panas di hipotalamus. Absorpsi baik melalui sejumlah rute peroral ataupun rektal. Metabolisme melalui hati, dan sebagian besar diubah menjadi metabolit inaktif dan sebagian kecil menjadi metabolit antara yang bersifat hepatotoksik. Dapat diinaktifkan oleh glutation hati. Sekitar 85-90% diekskresi melalui ginjal. Efek samping yaitu mual, sakit perut bagian atas, gatal-gatal, kehilangan nafsu makan, urin berwarna gelap, feses berwarna pucat, kuning pada kulit dan mata, reaksi alergi yang dapat menyebabkan ruam dan bengkak. Interaksi obat. Penggunaan bersamaan dengan obat cermazepin, phenytoin, phenobarbital, cholestyramine, imatinib akan menurunkan efek dari paracetamol. Contoh sediaan analgetik yang beredar di pasaran, yaitu morfin, morfina ampul 10 mg per mili, tramadol HCl, dolgesic ampul 50 mg per mili, paracetamol, panadol tablet 500 mg, natrium diklofenak, atranak, tablet 25 mg, juga terdapat tablet 50 mg, piroxicam, grazeo, tablet 20 mg, kodein tablet 10 mg, juga terdapat tablet 20 mg, fentanyl ampul 0,05 mg per mili. Mari kita masuk ke pembahasan berikutnya, yaitu anti-Parkinson. Apa itu Parkinson? Parkinson yaitu penyakit yang disebabkan karena berkurangnya neuron dopaminergik di area substans nigra sekitar 70-80% yang berperan dalam mengontrol motorik ekstrapiramidal sehingga menyebabkan timbulnya sejumlah gejala khas seperti bradykinesia, kekakuan otot, tremor yang menetap, gangguan keseimbangan pada postur tubuh, muka topeng, hipersalivasi. Pengertian dan senyawa obat anti-Parkinson. Obat anti-Parkinson digunakan untuk mengobati gejala penyakit Parkinson atau gejala yang serupa dengan Parkinson, seperti tubuh gemetar, kaku, dan kesulitan bergerak, yang umumnya disebabkan karena kurangnya kadar dopamin di dalam otak. Senyawa-senyawa obat anti-Parkinson seperti levodopa, agonis reseptor dopamin, inhibitor COMT, inhibitor MAO, amantadin, dan antimuskarinik. Di sini terdapat video mekanisme anti-Parkinson. Mari pelajari video dari channel Speech Pharmacology berikut ini.
In this lecture, we are going to cover the pharmacology of drugs for Parkinson's disease. So let's get right into it. Parkinson's disease is a neurological disorder that results in a progressive loss of coordination and movement. Now, the neurons responsible for coordinating movement are located in a part of the brain called striatum, which receives information from two major sources, the neocortex and a region known as the substantia nigra. The cortex relays sensory information as well as plans for future action, while the substantia nigra sends dopamine that helps to coordinate all of the inputs. Now, Parkinson's disease develops when the neurons connecting the substantia nigra to the striatum progressively degenerate. Since dopaminergic neurons that originate in the substantia nigra normally exert inhibitory effects on GABA neurons located in the striatum, too little dopamine results in more GABA, causing increased inhibition of the thalamus, as well as reduced excitatory input to the motor cortex. In addition to that, these same dopaminergic neurons also exert inhibitory effects on the excitatory cholinergic neurons in the striatum. And again, without sufficient levels of dopamine, the production of acetylcholine is increased, which triggers a chain of abnormal signaling leading to impaired mobility. Ultimately, the imbalance between inhibitory and excitatory activities leads to the manifestation of typical clinical symptoms that include resting tremor, rigidity, postural instability, and slowed movement. The pharmacological therapy for Parkinson's disease is aimed at replenishing dopamine levels, mimicking dopamine's action, or antagonizing the excitatory effects of cholinergic neurons. Now, in order to get a better understanding of the pharmacology of anti-Parkinson agents, first we need to take a closer look at the dopamine-producing neuron. So here, inside this dopaminergic neuron, dopamine is synthesized in a two-step process, starting with the amino acid tyrosine. First, with the help of enzyme tyrosine hydroxylase, tyrosine gets converted to L-DOPA, also known as levodopa. In the second step, the L-DOPA formed by tyrosine hydroxylation is quickly decarboxylated by another enzyme called aromatic L-amino acid decarboxylase to the neurotransmitter dopamine. Dopamine is then loaded into synaptic vesicles and released by physiological stimuli into the extracellular space, where it can bind to dopamine receptors that are expressed on the postsynaptic neuron. Finally, excess dopamine in the synapse is reuptaken back into the neuron or into glial cells, where it gets metabolized by monoamine oxidase, abbreviated MAO, and catechol O-methyltransferase, abbreviated COMT. It's important to note that while the MAO enzyme exists in two forms, known as type A and type B, the type that is predominantly found in the glial cells is the MAO type B. Now let's move on to discussing drugs used in treatment of Parkinson's disease, starting with one of the most commonly used drugs, that is levodopa. But first things first, you may wonder, well, why would you use the precursor of dopamine instead of dopamine itself? And the answer is, it's because of the blood-brain barrier. Blood-brain barrier is a tightly packed layer of endothelial cells that restricts free access of molecules between the blood and the brain. Dopamine happens to be one of those molecules that cannot freely pass through this barrier. However, levodopa can, with a little bit of help. One of the biggest problems levodopa faces on its own is peripheral metabolism. There are two major enzymes in periphery which cause breakdown of levodopa before it can reach the brain. That is peripheral dopa decarboxylase, which converts levodopa to dopamine, and catechol O-methyltransferase, which converts levodopa to 3-O-methyl-dopa. Because of this, levodopa must be administered with another agent, called carbidopa, which inhibits dopamine decarboxylase and thus reduces metabolism of levodopa in the periphery. Another agent that is used in combination with levodopa and carbidopa is entacapone, which inhibits peripheral COMT, and thus, just like carbidopa, it prolongs the time that levodopa is available to the brain. Now, levodopa is carried across blood-brain barrier by amino acid transporter. Once inside the brain, levodopa is efficiently converted to dopamine, thus supplementing depleted dopamine levels in the midbrain. However, let's not forget that dopamine is also susceptible to breakdown by COMT as well as MAOB, which convert dopamine to 3-methoxytyramine and 3,4-dihydroxyphenylacetic acid respectively. So here another useful drugs come into play, namely selegiline and rasegiline, which selectively inhibit MAOB, and tolcapone, which inhibits COMT. As a side note here, in comparison to entacapone, tolcapone can better penetrate the blood-brain barrier and thus can act both in the central nervous system and in the periphery. So again, as you can see, by decreasing the metabolism of dopamine, these drugs help to increase dopamine levels in the brain. Unfortunately, because Parkinson's is a progressive disease, with time the number of dopamine-producing neurons decreases, and fewer cells are capable of making dopamine. Taking that into consideration, some drugs have been developed to mimic dopamine and directly stimulate dopamine receptors in the brain. Drugs that belong to this class include bromocriptine, ropinirole, pramipexole, rotigotine, and apomorphine. Now, as I mentioned at the beginning of this lecture, in Parkinson's disease, dopamine depletion leads to increased acetylcholine release, which then activates muscarinic receptors located on the neurons responsible for smooth motor control. The overstimulation of these neurons by acetylcholine then causes tremors and rigidity. This is where anti-muscarinic agents come into play by blocking the muscarinic acetylcholine receptors and cholinergic nerve activity. As a result, these anticholinergic agents restore the balance between acetylcholine and dopamine, which may improve the symptoms of Parkinson's disease. Drugs that belong to this class include benztropine, biperidan, procyclidine, and trihexyphenidyl. Now, before we move on, I wanted to briefly mention here one more drug used in the treatment of Parkinson's disease, that is amantadine. Amantadine doesn't exactly fit into any of the classes that we discussed so far. Its mechanism of action is poorly understood. However, some of the speculated ones are that it prevents dopamine reuptake, facilitates presynaptic dopamine release, and blocks glutamate and NMDA receptors. Now, when it comes to side effects, levodopa in combination with carbidopa may cause nausea, loss of appetite, hypotension, mental disturbances, and discoloration of urine, sweat, or saliva. Selegiline and rasegiline may cause nausea, insomnia, dyskinesia, and visual hallucinations. Entacapone and tolcapone may cause discoloration of urine, sweat, or saliva, and diarrhea, which can get severe, particularly with the use of tolcapone. In addition to that, tolcapone has been associated with liver toxicity. All dopamine agonists may cause nausea, orthostatic hypotension, mental disturbances, and daytime sleepiness. In addition to that, bromocriptine has been associated with pulmonary and cardiac fibrosis. Lastly, drugs that block muscarinic receptors generally produce anticholinergic side effects, such as constipation, urinary retention, dry mouth, and blurred vision. And with that, I wanted to thank you for watching. I hope you found this video useful, and as always, stay tuned for more.
Berikut adalah gambar dari mekanisme obat anti-Parkinson seperti levodopa, selegiline, amantadine, dan bromocriptine pergolide dari D2 reseptor. Senyawa anti-Parkinson, kita ambil contoh yaitu levodopa. Levodopa merupakan prekursor dopamin yang mengalami dekarboksilasi menjadi dopamin. Levodopa mampu melewati saluran darah otak, sedangkan dopamin tidak. Mekanisme levodopa: absorpsi. Levodopa diabsorpsi melalui saluran cerna seperti sistem transport asam amino. Adanya makanan kaya protein dapat memperlambat penyerapan levodopa. Distribusi. Kadar levodopa di sirkulasi sistemik dan yang mencapai otak rendah sekitar kurang dari 1%. metabolisme. Levodopa mudah mengalami dekarboksilasi pada saluran pencernaan sehingga kadar dopaminnya mencapai otak rendah. Diatasi dengan pemberian inhibitor dekarboksilasi. Ekskresi 70-80% diekskresi melalui ginjal. Efek samping levodopa yaitu hipotensi, aritmia, mual, disorientasi, halusinasi, dan juga bingung. Interaksi obat levodopa bila diberikan bersama piridoksin dapat menurunkan efektivitas levodopa. Pemberian bersama makanan dapat memperlambat onset levodopa. Pemberian bersama inhibitor MAO non-spesifik dapat memicu hipertensi krisis. Agonis reseptor dopamin, bromokriptin, pramipexol, propinerol, dan apomorfin. Memiliki durasi efek lebih lama, 8-24 jam, dibanding levodopa yang hanya 6-8 jam. Bromokriptin bertindak sebagai agonis reseptor D2 dan antagonis parsial D1. Propinerol dan pramipexol bertindak sebagai agonis reseptor D2 dan D3. Lebih mudah diterima pasien dibanding bromokriptin. Efek samping seperti halusinasi, bingung, hipotensi osteopatik, mual, mengantuk, dan terjadinya fenomena on-off. Apomorfin memiliki efek samping mual dan muntah yang kuat, sehingga harus diberikan antiemetik yaitu trimethobenzamin peroral pra dan pasca injeksi apomorfin. Inhibitor COMT, tolcapone dan entacapone, bekerja menghambat penguraian dopamin oleh COMT, control orthomethyl transfer, menjadi metabolit non-aktif di sistem saraf pusat dan perifer. Umumnya digunakan bersama levodopa, carbidopa untuk memaksimalkan kerja levodopa. Entacapone tidak bersifat hepatotoksik. Inhibitor MAO-B seperti selegiline menghambat secara selektif enzim penguraian dopamin di sistem saraf pusat dan melindungi dopamin dari penguraian intraneuron. Tidak menimbulkan hipertensi krisis. Digunakan untuk terapi tambahan apabila efek levodopa mengalami toleransi. Antimuskarinik seperti biperidin, diheksilpenil, triperidin. Senyawa sintesis yang bekerja memblok reseptor muskarinik di sistem saraf pusat sehingga mampu mengurangi ketidakseimbangan aktivitas dopaminergik. Digunakan hanya untuk pasien Parkinson usia muda yang dominan mengalami tremor dan rigiditas. Efek terapi mengurangi tremor, kekakuan otot, dan hipersalivasi. Efek samping mulut kering, pandangan kabur, konstipasi, retensi urin, glaukoma, halusinasi, penurunan daya ingat, dan psikosis. Contoh obat anti Parkinson yang beredar di pasaran, seperti selegiline, Jumek tablet 5 mg, bromokriptin, Parlodel tablet 2,5 mg, pramipexol, Cifrol, tablet lepas lambat 0,375 mg, triheksilpenidil, Artani, tablet 2 mg, levodopa plus benserazid, Pardos, kombinasi levodopa 100 mg dan benserazid HCl 25 mg. Oke, kita masuk ke pembahasan terakhir, yaitu hipnotik-sedatif. Pengertian hipnotik dan sedatif. Hipnotik yaitu senyawa yang mampu menghasilkan efek drowsiness dan mempercepat onset dan memperpanjang durasi tidur. Sedangkan sedatif atau ansiolitik merupakan senyawa yang berefek untuk menurunkan aktivitas dan menimbulkan rasa tenang atau mengantuk. Obat hipnotik sedatif. Obat sedatif hipnotik menimbulkan rangkaian efek depresan sistem saraf pusat mulai dari sedasi ringan, meredakan anxietas sampai anestesi dan koma. Barbiturat dan benzodiazepin adalah grup sedatif hipnotik yang paling penting. Berikut merupakan penggolongan dari obat hipnotik sedatif. Golongan barbiturat seperti fenobarbital, pentobarbital, sekobarbital, amobarbital, dan alobarbital. 2. Golongan non-barbiturat seperti benzodiazepin lainnya. Contoh obat diazepam, clozapam, lorazepam, entazepam, oxazepam, temazepam, lorazepam, alprazolam, nitrazepam, prazepam, triazepam, dan demetildiazepam, dan masih banyak lagi. Mekanisme kerja obat hipnotik sedatif. Meningkatkan kapasitas pengikatan neurotransmitter GABA pada reseptornya. Meningkatkan aktivitas inhibisi saraf pusat. Mengaktifasi reseptor melatonin, MT1 dan MT2 di hipotalamus sehingga memperpendek onset tidur. Di sini ada video mekanisme kerja obat hipnotik sedatif. Mari pelajari video dari channel Speed Pharmacology berikut ini.
In this lecture, we're going to cover the pharmacology of anxiolytic and hypnotic drugs. So let's get right into it. The primary use of anxiolytic and hypnotic drugs is to treat anxiety and insomnia. Anxiety is generally defined as an emotional state characterized by excessive feelings of worry, fear, and nervousness, while insomnia is generally defined as the inability to initiate, maintain, or achieve restful sleep. Now, in order to gain better understanding of how anxiolytic and hypnotic drugs work, first we need to discuss the role of GABA in the central nervous system. So, gamma-aminobutyric acid, or GABA for short, is a major inhibitory neurotransmitter. What that means is that when GABA reaches and binds to a specific receptor located on a neuron, it reduces the activity level of that neuron and makes it less likely to fire its action potential. Now, GABA is recognized by both ligand-gated and G-protein-linked GABA receptors. In this lecture, we are going to focus on the ligand-gated GABA receptor called GABA-A, as this is the main target of many anxiolytic and hypnotic agents. Now, the GABA-A receptor is made up of 5 subunit proteins arranged to form a central pore. These subunits have been labeled with Greek letters such as alpha, beta, gamma, and delta. The subunit composition of GABA-A receptors in the brain most frequently consists of 2 alpha subunits, 2 beta subunits, and 1 gamma or delta subunit. Furthermore, for each subunit, many other subtypes exist. The function of each GABA-A receptor depends on which subunit it contains. For example, GABA-A receptors containing alpha-1 subunit appear to be involved in sleep, while those that contain alpha-2 or alpha-3 appear to be involved in anxiety. Now, when 2 GABA molecules bind to the GABA-A receptor, conformational change is induced, which results in opening of the central pore that allows negatively charged chloride ions to rush into the cell. This in turn increases the negative charge inside the postsynaptic cell, which makes more difficult for an excitatory inputs to cause an action potential. Now, GABA-A receptors are present in high concentration in the limbic system. One part of the limbic system is the amygdala, which contains many neurons that use the neurotransmitter GABA to control feelings of fear and anxiety. In times of stress, excitatory neurons in the amygdala fire rapidly, sending excitatory signals to other areas of the brain. It is this type of firing that leads to feeling of panic or fear. The inhibitory interneurons in the amygdala regulate these emotions by releasing GABA. The release of GABA and its binding to postsynaptic receptors such as GABA-A inhibits the excitatory signals that result in feelings of anxiety and fear. GABA thus has a calming, tranquilizing effect on our emotions and prevents us from becoming overwhelmed in stressful situations. Now, in addition to a distinct binding site for the neurotransmitter GABA, the GABA-A receptor has also a site at which anxiolytic and hypnotic drugs bind. These drugs can be divided into 3 groups, that is, benzodiazepines, barbiturates, and non-benzodiazepine hypnotics. Let's now discuss these one by one in detail, starting with benzodiazepines. So benzodiazepines get their name from their chemical structure, which includes a benzene ring fused to a diazepine ring. Their binding site appears to be the region between the alpha and gamma subunit on the GABA A receptor. It's important to remember that benzodiazepines do not bind to the GABA recognition site located at the junction of the alpha and beta subunits. Thereby, they don't induce opening of the channel as directly as GABA. Instead, the binding of a benzodiazepine to its receptor site increases the affinity of GABA for the GABA binding site. This leads to increased frequency of the channel opening and in turn increased influx of chloride ions at the postsynaptic cell, which ultimately makes it difficult for any excitatory inputs to cause an action potential. So when the excitatory signals caused by fear or stress are inhibited in this way, the result is decreased anxiety and greater feeling of calm. In addition to that, benzodiazepines can also produce mild muscle relaxation as a result of their action on GABA receptors in the spinal cord, cerebellum, and brainstem. The examples of benzodiazepines are alprazolam, chlordiazepoxide, clonazepam, diazepam, lorazepam, and temazepam. When it comes to side effects of benzodiazepines, the most common ones are related to their sedating and muscle relaxing action. They include drowsiness, dizziness, decreased alertness and concentration, as well as impairment of motor coordination. Now let's move on to the next group, that is barbiturates. So barbiturates bind to GABA A receptor at the alpha or beta subunit, which is different from the GABA binding site and also different from the benzodiazepine binding site. Now, just like benzodiazepines, barbiturates enhance the effect of GABA at the GABA A receptor. However, instead of increasing the ion channel opening frequency, they increase the ion channel opening duration. In other words, unlike benzodiazepines, barbiturates hold the ion channel open continuously for long periods of time. In addition to that, barbiturates can decrease the activity of excitatory neurotransmitters such as acetylcholine and glutamate, and at higher doses, they can also mimic GABA and directly activate GABA receptors, thus leading to profound central nervous system depression. This is why barbiturates have a much lower therapeutic index than benzodiazepines, meaning the toxic dose is not much higher than the therapeutic dose. The examples of barbiturates include pentobarbital, phenobarbital, and secobarbital. When it comes to side effects, barbiturates most often cause dizziness, lightheadedness, sedation, as well as memory and attention impairments. Furthermore, because of their narrow therapeutic index, it's important to remember that even small barbiturate overdose can result in coma or death due to respiratory depression. Now let's move on to our last group of drugs, that is non-benzodiazepine hypnotics. As I mentioned at the beginning of this lecture, GABA A receptors in different areas of the central nervous system consist of various combinations of the subunits. The specific subunit that appears to mediate sedation is the alpha-1 isoform. So as their name suggests, non-benzodiazepine hypnotics are structurally different from the benzodiazepines, and as you may already guess, they selectively bind to the alpha-1 subunit of the GABA A receptor, thus triggering chloride channel opening with resulting membrane hyperpolarization. Because alpha-1 containing GABA A receptors are highly expressed in wake-promoting regions of the brain, the preferential binding of non-benzodiazepine hypnotics to these receptors results in sleepiness but not anti-anxiety effect. The examples of non-benzodiazepine hypnotics are zolpidem, zaleplon, and azopiclone. When it comes to side effects, non-benzodiazepine hypnotics can cause cognitive impairments, including memory loss, daytime sedation, as well as impairment of motor function. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
Golongan barbiturat. Efek sedatif hipnotik ditimbulkan dari perpanjangan aktivitas GABA melalui perpanjangan influx ion klorida pada neuron. Fenobarbital efektif digunakan untuk mengatasi hiperbilirubinemia dan kernicterus pada neonatus, mengontrol serangan epilepsi. Efek samping barbiturat menghasilkan efek residual, depresi SSP, gangguan mood dan psikomotor, vertigo, mual, muntah, dan diare. Kegirangan idiosinkrasi dapat timbul reaksi hipersensitivitas pada pasien yang memiliki riwayat alergi, seperti bengkak di lokasi penyuntikan, kelopak mata, bibir, dan dagu. Interaksi obat barbiturat. Kombinasi dengan senyawa depresan sistem saraf pusat terutama alkohol dapat menimbulkan depresi sistem saraf pusat berat. Kombinasi dengan isoniazid, metilfenidat, inhibitor MAO dapat menimbulkan depresi sistem saraf pusat berat. Dapat menurunkan kadar sejumlah obat dalam darah ketika dikombinasikan dengan barbiturat penginduksi enzim CYP. Golongan non-barbiturat. Benzodiazepin. Benzodiazepin mampu memperpanjang waktu tidur, memiliki efek antikonvulsan, dan digunakan pada prosedur pre-anestesi, tetapi tidak mampu menghasilkan efek anestesi meski bekerja meningkatkan aktivitas inhibisi di sistem saraf pusat. Penggolongan benzodiazepin berdasarkan T setengah eliminasi. A. Benzodiazepin kerja pendek, yaitu short acting, seperti triazolam, zolpidem, dan zopiclone. B. Benzodiazepin kerja menengah, yaitu intermediate acting, seperti estazolam dan temazepam. C. Benzodiazepin kerja panjang, yaitu long acting, merupakan jenis benzodiazepin yang digunakan untuk mengatasi gangguan kecemasan seperti flurazepam, diazepam, dan kuazepam. Efek sampingnya yaitu letih, gangguan psikomotor, termasuk gangguan pengemudi, sakit kepala, pandangan kabur, vertigo, mual muntah, dan diare. Interaksi obat. Depresi tambahan berat jika bersama alkohol, antihistamin, antidepresan, analgesik opioid, dan fenotiazid. Jangan diberikan bersama inhibitor MAO seperti isokarboksazid, phenelzin, dan tranilsipromid. Contoh sediaan hipnotik-sedatif yang beredar di pasaran: estazolam, Zolacare tablet 25 mg, diazepam, Valtrex tablet 5 mg, Zaleplon kapsul 5 mg, terdapat juga 10 mg, Zopidem, Astinok tablet 10 mg. Oke, selesai pembahasan dari saya tentang analgetik, anti Parkinson, dan hipnotik-sedatif. Apabila terdapat kesalahan dari video ini, saya memohon maaf. Assalamualaikum warahmatullahi wabarakatuh. Sekian dan terima kasih.